Hello, welcome back to my channel. I'm going to be talking about medications for use in the maternal child health setting today. And this video will be useful for anyone that is maybe studying for NCLEX or is currently a nursing student, either a vocational nurse or a registered nurse, and trying to get through their maternal child health course. So I like to study medications in the way that they're being used. So I break them up into sections. So we actually will talk about the same medication for different uses. Okay, let's get started. Okay, so as we are talking about our medications for maternal child health, I'm going to talk about the 8 rights of medication administration. Now, every year it seems we add a right to the number of rights that we're supposed to do before we give medication, but specifically the 8 rights for maternal child health are important because we add the right reason and the right response. The big difference between medications for the general population or pediatrics and this population is that we use medications in an off-label use, meaning that we're using them for not necessarily the purpose that they were created. And I'll discuss more about that in a minute. But that's why we have added an additional right. So we have all the same rights: right patient, right medication, right dose, right route, right time, right documentation. And then we add right reason and right response. There actually have been a couple more added since that time, but for our purposes today, this is what we're going to use. So I call them the 8 rights of maternal child health. So the other rules that we have is all medications that are given to pediatric patients require an independent nurse double check. Now, on some of the other units and the other floors, we will see that some high-risk medications require an independent double check, but just to make sure when we're giving medications to this vulnerable population, we want all of our medications to be double checked independently before given. And most of the time, most facilities will also require a signature with that double check. Any medication labeled as high risk by the pharmacy will also be an independent RN double check, and all wasted narcotics require an additional nurse to witness, and that there are no breaks in the chain of custody. So what that means is I can't pull a narcotic out and then hand it to my buddy to go give it. I need to, if I pull a narcotic out under my name, I need to make sure that I'm giving that medication and I'm also documenting the witness. And I'll just say here, we get very comfortable with the people that we work with. And a lot of times you might have someone say, oh, I already wasted it. Can you sign this? I wouldn't recommend it, because every time you're witnessing the documentation, you are saying you saw them throw it away. So just stay on the up and up and make sure you actually do see them throw it away. So what an independent nurse double check means is that each nurse independently, without each other's influence, goes in and performs those 8 rights. So I would go in, perform my 8 rights, and then ask my nurse partner to come in, and they would perform their 8 rights without my influence. And that way you have 2 people that are independently going through the process, and this is how we can avoid medical errors. And I'll let you read through here. I just gave an example of one hospital system that I am familiar with. They use a name and a birth date as an identifier, but I'm going to let you go through and read what each of these things mean as far as the rights for the medication. And I'll let you read through those as well. And then are added to. Every nurse giving a medication should be able to answer these 5 foundational questions. This comes from Keith RN and his publication from 2018. And so a lot of times I'm asked, what should I know about this medication? Well, every medication that is given by a nurse, we should be able to answer these questions. What is the pharmacological class? What is it for? Why is my patient receiving it? And this is especially important in this area again, because we might be using this medication in a different way. What's the expected response based on the mechanism of action? What assessments do I need to know before I administer? And what follow-up assessments do I need? And is this a safe dose? Is it in the high range, middle range, or low range? And a lot of times my students will ask me, well, there's a pharmacist that is checking these meds and there's a doctor that's ordered these meds. Isn't it my job just to give them? It is true that we are following the physician order and we are required to give the medication as ordered, but we are also required to be a patient advocate. And in order to do that, we need to know, is this medication being ordered properly? Because we are all human and there is a possibility of making a mistake. There's even a possibility, anywhere in the chain, there's a possibility of a mistake being made. So it could be made at the level of the order. It can be made at the level of the entry of the order. The pharmacist could make an error. The pharmacy tech that's putting it into the Omnicell or Pyxis, whatever system you're using, could make an error. We could make an error when we pull it out. If we are able to do these 8 rights every time, we should not be making any medical errors. And unfortunately, that's not the case. In this day and age, we are still making about 200,000 errors a year where patients are harmed and or killed by those medical errors. Here are some other helpful definitions that you will see used with the medications that we're going to be talking about. High alert, these are meds that have been associated with significant harm. Off-label use, this is when the drug has been approved by the FDA for a specific purpose and we are using it for a different purpose because maybe it has a side effect that we're looking for. For instance, the medication Cytotec is used for gastric ulcer prevention, but its little side effect that we found is that it causes uterine contractions. So we use a medication that's meant for gastric ulcers to cause contractions. All over the packaging, it says, do not give to pregnant women, even though we're giving it to pregnant women. We know that the side effect, we're looking for the side effect that it causes. Teratogenic is leading to irreversible changes in structure or function. So if I give a medication that's teratogenic to a mother who is newly pregnant, first trimester, we can actually change the development of that fetus. A tocolytic is a drug that's used to suppress or inhibit labor, so that's when we want it to stop, and a uterotonic is used to stimulate uterine contractions, either to cause labor or increase labor contractions or to increase the contractions of the uterus once it's empty. So this is why we would use the same medication in 2 different ways. So I'm going to start with the medications that we use in our antepartum or interpartum patients. That is during pregnancy or during birth. And we'll start with some antibiotics. Now, antibiotics, no matter where you are in your study, you have studied antibiotics. There's some specific ones that we use in labor and delivery because everything that we're giving to mom, we're also giving to baby. And so one of the antibiotics that we use pretty frequently is when we're looking for our GBS prophylaxis. GBS, group B strep, is bacteria that sometimes will colonize in the perineal area or rectal area. It's a non-sexually transmitted colonization. Colonization is not the same thing as being infected, but sometimes we'll find that on a swab that we do towards the end of pregnancy. And if a mom is colonized with group B strep, then we will want to give her some antibiotics prophylactically to break down that colonization. Babies that are born to moms that have this colonization are more likely to contract group B strep, sepsis, and they don't do very well if they do contract that. So we use GBS prophylaxis, group B strep prophylaxis. The drug of choice is actually Pen-G. One of the things about penicillin G is that it burns when it goes into the vein. This is one of the reasons we want to have really good placement of our IV sites and with a pretty large catheter, pretty large diameter catheter and in a large vessel, because when we have to put medications that are very caustic to the vessel, that burn. This is one of them. Magnesium sulfate's another one. We want to make sure that we can dilate that vessel so that it won't burn as much. So one little trick is to put warm, some sort of warming device, either a warm blanket or even heel warmers around that site to help dilate the vessel so that it doesn't burn as much. So an alternative to using penicillin G is ampicillin, and that will be provider specific. It will be up to the provider which one they choose, and you will see differences in providers and what they choose. But GBS prophylaxis, there is a CDC recommendation of what medications need to be used, and our key is we want at least 2 doses of this antibiotic in before baby is born, because we know that by having 2 doses, and it's usually 4 hours apart, we have cut that bacteria down to a level that has decreased the possibility of the baby being contracting that infection. We are still going to be watching for signs of sepsis in our newborn, and in other videos we will discuss what those signs of sepsis are. We also use a surgery prophylaxis, and depending on the facility, again, you may see different antibiotics. Sometimes you'll see cefazolin, also known as Ancef. Sometimes you'll see gentamicin and zithromax. So again, these are facility specific, but knowing what medications are supposed to be ordered before surgery is an important aspect of being a patient advocate. And then if we do have suspected sepsis or confirmed sepsis, then you might see any of these medications utilized. And I'm not going to go through each one of those because antibiotics are used pretty universally throughout the different specialties. So these aren't specific to OB, just that these are the ones that are safe to use in pregnancy and in postpartum. I'm going to move into tocolytics. Now we have lots of different types of tocolytics. Tocolytic, again, is to stop contractions, to slow them down. There are certain ones that can be used in certain circumstances. So for instance, we can use nifedipine, which I know you've heard of before, Procardia, which is a calcium channel blocker. It's a smooth muscle relaxer, and our uterus is a smooth muscle. So we can give nifedipine to try to slow down preterm labor. Now, obviously, we wouldn't give this in someone that is actively laboring and changing that cervix. So lots of side effects to think about when we are giving this medication, and it is absolutely contraindicated in myasthenia gravis. So we need to know what our patient's history is before we give this medication. We still want to check our blood pressure and our pulse before giving this med, and just like you would in any other unit. We can also use Induction in a pregnancy that is at or after 32 weeks gestation. We don't want to use this, it's contraindicated in a pregnancy that's at or after 32 weeks gestation, and that's because it will cause the premature closure of the ductus arteriosus. That's that vessel inside the fetal circulation that's keeping everything shunted away from the lungs, and the placenta is doing the work there. So you don't want to give this after 32 weeks. So before 32 weeks, we will use Induction. And then terbutaline is another medication that you do see used pretty frequently. This is a subcutaneous injection. It's only a 0.25 milligrams. There are some places around the country that will allow this to be given IV, not in any of the systems in our local area. We don't give this medication IV. There's been some studies that suggest that it can cause PEs if we give it the IV route, but there are some places around the country that are still utilizing that. We have to make sure that we tell the patients what the side effects are. Terbutaline is one of those medications that once you give it, they actually feel worse rather than better. It can include shortness of breath, tachycardia, palpitations, tremors, headaches. A lot of women describe it as feeling like they've had several cups of caffeine. So we want to make sure that we check their pulse before we give that terbutaline. It's depending again on your facility, they're going to set a parameter of when it's okay to give it and when it's not, based on the patient's pulse. And usually this is a 2-dose maximum. Now, one little thing about terbutaline is it comes in a 1 milligram vial. So we have to know how to draw up 0.25 milligrams out of a 1 milligram vial. Super important to be able to know how to do that math to get your syringe to be appropriate. It's 1 milligram per 1 ml. So you're going to draw up 0.25 in a 1 ml syringe. Another tocolytic that is utilized is magnesium sulfate. Now, magnesium sulfate, some of the current research tells us that it isn't a fantastic tocolytic, but we use it for another purpose in our preterm moms. It actually is given to mothers in preterm labor for neuroprotection of that premature baby. Magnesium sulfate isn't a beautiful tocolytic just for the preterm contractions specifically. It's been used that way for a lot of years, but evidence-based research tells us that that's not the best use of it, that the benefit of it slowing down the contractions does not outweigh the negatives. But you will still see it used. Sometimes it will be used so that we can get some other medications on board that I will talk about in just a minute. And then sometimes it'll be used for that neuroprotection. So the side effects: headache, nausea, vomiting, dizziness, flushing, sweating, hypotension, we see those pretty frequently, especially at the dosages that we're giving. You'll notice here that we're giving a loading dose of 4 to 6 grams over 20 to 30 minutes. That is a very large dose. When you are giving a magnesium sulfate bolus, it's a high-risk medication, so you are going to have 2 nurses verify it, and you are going to be at the bedside doing frequent assessments of your patient. They can become mag toxic very quickly. And depending on the reason you're giving it, because there's other uses for this medication, preeclampsia being one of them, they may already be ill. And so blasting their system with a large dose of this calcium channel blocker can cause some pretty detrimental effects. And I will talk more about that in just a minute. So when we are giving our mag bolus, we want to be at the bedside the entire time for that, while that bolus is going in. And then we're going to do frequent monitoring of this patient. You should be in that patient's room at least every hour, checking on them. And one of the adverse effects that we see of magnesium sulfate is respiratory depression. We also see depressed reflexes, muscle weakness, decreased urine output. All of these things are what we're looking for. So when you have a patient on a magnesium sulfate maintenance dose, you're going to be going in every 1 hour to 2 hours, depending on your patient, depending on your policy, and looking at respiratory rate, reflexes, and urine output, and lung sounds to make sure she can still take a deep breath. The signs of magnesium toxicity are when they no longer can take a deep breath, or they have complete respiratory failure, respiratory arrest, or they have a heart block. So we need to be watching their blood pressure very closely. One of the things we see with magnesium sulfate is that it does decrease the blood pressure because it's a calcium channel blocker, and it causes relaxation of that smooth muscle. And so we do see decreased blood pressure. That's not why we give it in preeclamptic patients. We give it to a patient that is preeclampsia to decrease the risk of seizing, but we like the little side effect that it also is bringing down their blood pressure. So if you were in NCLEX and you were taking your test and you got a question is, what's the main purpose of using magnesium sulfate in a hypertensive patient? It is not to decrease the blood pressure. It is to prevent seizures. Okay, so there's a little hint for you. We want to make sure that we're checking those reflexes, because the reflexes will be the first thing that goes. We want to make sure that we're checking their urine output, because the magnesium sulfate is cleared through the kidneys. And if we have decreased urine output, then that magnesium sulfate will be building up, building up, building up. So we are looking for a therapeutic value. Again, each hospital is going to set their own standard, but in order for a patient to be at a therapeutic dose, it's somewhere between 6 and 8 milligrams per deciliter. Once they get past that, we are now moving into the level of respiratory depression, respiratory paralysis, and potential cardiac arrest. And we certainly don't want to do that. Again, contraindicated in myasthenia gravis, hypocalcemia, heart block, and renal failure. So here is a slide that lists all your nursing interventions for magnesium sulfate, all the things I just talked about, a nice little slide for you. As you're creating your medication reference, these are the types of things that you would want to have on that reference card. These are the little tips and hints. Now, some of our medications have an overdose antidote. So if you have overdosed, if your patient is magnesium sulfate toxic, and you need to reverse the effects, your antidote for this is calcium gluconate. It's important to have that available at the bedside when you are running magnesium sulfate. Some hospitals have it in a locked box that you keep in the room. Some have it just immediately available through a Omnicell system, but you must have that antidote readily available. And if you are giving an antidote like calcium gluconate, because your patient is not breathing, it is definitely a fast push, as fast as you can get it in there. The other medications that we might use on our patient that we're worried about is delivering early would be corticosteroids. In our moms that we're concerned about a baby coming early, we want to get some steroids on board. We give it to the mother, but the action is it increases the surfactant production in the fetus. And the surfactant production is what allows this full respiratory process to happen. So if our mom, if she is imminently going to deliver a preterm baby, we usually use these medications in the 24 to 34 week gestation, but there is some current evidence that says we use it all the way up until 39 weeks. And some physicians are following that. It won't hurt the mom to have it if it's not needed. So if we give these 2 doses of medication, either betamethasone or dexamethasone, it depends on the provider, then we can increase that surfactant and we see less respiratory distress syndrome in our neonates. So betamethasone is given, it's a 2-dose regimen and it's given once every 24 hours. So this might be one of the reasons that we use our magnesium sulfate to try to hold off that delivery, also using it for neuroprotection of the fetus. But if we can hold off our delivery to get both doses in, we can decrease our chance of respiratory distress syndrome. Dexamethasone is every 12 hours. This says for 2 doses, but I actually think it's for 4. That would have to be looked up. One of the things that we do see when we give steroids to moms is we're going to increase that white blood cell count, and that may decrease the mother's resistance to infection. So if she's in preterm labor because she has an infection, this kind of counteracts what's going on there. Like we may make her more susceptible to that infection. Pregnant women are susceptible to infection regardless. And then we sometimes can see some pulmonary edema in steroid use. Usually not. That's pretty rare. But we also will see elevated blood glucose levels. So if the mom is diabetic, we may throw her blood glucose levels through the roof with this use of steroids. So it's important to remember what medications we have given this mom, because then when our labs come up, we can remind the physician, oh yeah, remember we gave her steroids 2 days ago, and that's why her blood sugars are now out of the normal ranges. So again, here are nursing interventions that you would want to utilize if you're giving your mom those steroids used to increase surfactant in preterm fetuses that are imminently going to be delivered. Prostaglandins. So now we're moving into medications that we would use to cause contractions or to cause cervical ripening. These two medications specifically, Cytotec and Cervidil, misoprostol and dinoprostin, are what we consider prostaglandins, and they are to ripen that cervix and help it get ready for the process of labor. So Cervidil is a medication that is a 12-hour dose, and it's a little flat tampon that is placed right up behind the cervix. And it sits there, releases its prostaglandin, and helps that cervix soften and get ready for labor. Cytotec is a pill, a tablet. It can be used both orally, vaginally, and rectally. And it's a very small amount of this medication, because this baby's on board, that we would want to give to the mom to cause the uterus to contract very gently, and that will serve the same purpose of ripening. Sometimes you will see these two used not concurrently, but sequentially. So you might see Cervidil for 12 hours, and then once that's been taken out, we might see some Cytotec used for another 12 or 24 hours. I'll say here that induction is a process. We're asking the body to do something in 12 to 24 to 48 hours that it normally does over weeks time. So if it's a medical induction, we are doing this because it's been deemed that it's better for the baby to be on the outside than on the inside, either for the baby's purposes or for the mom's purposes. For instance, gestational hypertension that's not well controlled, or gestational diabetes where the baby is growing very large, or a myriad of other reasons. Maybe the baby is telling us there's some placental insufficiency and it's time for this baby to be born. So if it's a medical induction, then we're going to work very hard at getting this cervix right, and then hoping to get this mom into labor. If it's an elective induction, meaning the only reason we want to do it is because it's convenient at this time, because it makes sense to do it at this time socially, because mom is tired of being pregnant, or her family is available at this point, then we want to make sure that we're looking at this Bishop score very closely. If the mom is requesting induction, which elective induction is still done in some parts of the country, if the mom is requesting induction, if her Bishop score, which is a scoring system to look at the cervix, is less than 4, we absolutely need to be using some sort of cervical ripening until we get that Bishop score up to an 8 or more. The reason is, if we start some other more aggressive ways of induction before that cervix is ripe and ready, we can almost guarantee she's going to end up with a cesarean section, a failed induction in a cesarean section. So the Bishop score is imperative. There are some adverse side effects that can come along with these medications, and it's contraindicated in patients that have these conditions, or in patients who a vaginal delivery is not indicated. Obviously, we would not want to use these meds if the baby's not in appropriate position for delivery, if there's a history of cesarean section or uterine scarring for other reasons, if there is any of these other conditions, we would not be using cervical ripening. Here are your nursing interventions that go along with the medications that we use for cervical ripening. I'm going to talk just a minute about pain and opioids. We do use some opioids in labor. We do have some limitations, because every time we're giving a medication to the mom, we're also giving it to the fetus. And because their systems are a little more immature, they do not cycle through and clear these medications from their bodies as quickly as an adult would. So we have some limitations to the amount of these meds that we could use. So sometimes you will see Stadol still used, and this is typically in those moms that are having some what we call prodromal or a long first stage. Stadol is one of those medications that has a little bit longer life to it, and we don't like to use this when we're expecting an imminent delivery. All pain medications that we use with all opioid pain medications that we're using in pregnancy can cause respiratory depression in the newborn. So we don't want to give this type of medication very close to anticipated delivery. So that's why Stadol is not used when we're actively laboring. Nubane is used in certain parts of the country and is very effective. And the dose is going to be provider specific, provider choice again. And then fentanyl. I know fentanyl sometimes can have a negative connotation because you hear about fentanyl in the news, but we're using 50 to 100 micrograms, which is not a giant dose. And we have a maximum of 6 doses in the entire labor for most facilities. So we want to use these medications sparingly if she is actively laboring. And we also want to give her a good idea of what to expect with these medications. These are not going to take labor pain away. They are merely going to help you relax and kind of take the edge off. It's not going to take away the pain completely. Some people really love how they feel on these meds, and some people really don't. So they'll have one dose and say, no, that's not for me. I don't want to use that medication anymore. Other things that you might see used, Dilaudid. Pretty infrequently do I see this used in labor, but occasionally. And then Demerol. Demerol was used in labor a long time ago, and occasionally you'll see it used nowadays, but it's pretty rare. But I put it on here just so you, in case you got an old NCLEX question about the medication. These are provider preference again. Side effects are the same as the previous page, and they all have the potential to cause respiratory depression or arrest in both mom and newborn, if the newborn is born shortly after administration. We should be doing some sort of sedation scale on every mother that we're giving opioids to, and this is an example of what that sedation scale is. So I always explain to my patients, if I'm going to be giving them opioids, I have, number one, a limit to how much they can have, and it depends on both them and the baby. And the baby, I'm going to be able to tell from the fetal monitoring system how they're tolerating it. And I also have to use a scale, something like this. If they are slightly drowsy, easily aroused, then I could probably give another dose. But if they're frequently drowsy and are drifting off to sleep and asking me for another dose, I'm probably not going to be able to give it to them until they wake up a little bit more. And so before I start the medication at all, I want to make sure they understand this. Other medications that can be used for pain, the first is nitrous oxide. This isn't everywhere in the United States, but it's been used in Europe for over 100 years with very good results. This is a laughing gas, and you may have heard of it used at the dentist's office. It's a little bit of a different concentration that we use in labor and delivery, and you have to have some special training for the nurses and some special equipment, but it is typically very well received, and it's controlled by the patient. The patient uses a mask, and only when she's breathing in that mask is she actually getting the nitrous oxide. It really takes away some of the anxiety and again just helps with relaxation. It does not take away the pain, but it is an anxiety relief, and sometimes that's all women need to be able to deal with their labor. Side effects: sleepiness, dizziness, lightheadedness, and mild sedation, but it's cleared from the body within 60 seconds. So as soon as that mask is removed from the face and the patient controls whether it's on the face or not, as soon as it's removed, it goes away completely within 60 seconds. And we have seen no effects on our babies from the use of nitrous oxide. Most of the research is pretty new from the United States, like I said, but we see virtually no effects. We do have to use this cautiously with women that have a vitamin B12 deficiency, so that could potentially be your vegans or people that have had a previous gastric bypass surgery. or gastric banding. Sometimes they will have vitamin B12 deficiency. And so that needs to be explored a little bit more and will be a provider specific decision. Other pretty common pain relief options are epidural anesthesia and spinal anesthesia. We see the epidural used typically for our labors, and the spinal is used for our planned cesareans. Now, if a mom has an epidural and has to go, now is going to a cesarean delivery, then they can utilize the same epidural space. They can utilize the same procedure to give more medication to get them through the surgery. But if they're planning a cesarean section, then they will usually just use a spinal. The difference is an epidural, they will place a catheter, either an anesthesiologist or a nurse anesthetist will place a catheter and it will stay placed with medication that drips continuously through it. If they are, and the spinal is where they don't place a catheter. They go a little bit deeper into the area and give a little bit heavier dose of the medication. And there is nothing that stays in that spot. And then it wears off, starts to wear off fairly quickly. So epidural is continuous infusion. This is a one-time dose. And there are some side effects to both of these. So one of the things that we typically see with either epidural or spinal anesthesia is a drop in the blood pressure. Because it causes a vasodilation, we see a drop in blood pressure. And so we are counteracting that drop in blood pressure with some fluid bolus at the time. Most facilities are now using the evidence-based practice of giving the fluid at the same time concurrently as the procedure. We want to try to counteract that hypotensive process that we're going to see with the mom. We also sometimes will see nausea, vomiting, and that is usually associated with that drop in blood pressure and can be controlled with medication if necessary to bring that blood pressure back up if the bolus didn't do it. And then itching. Itching is a very common side effect from both epidural and spinal anesthesia, and we need to let the mom know what to expect as far as that itching goes. And of course, there's medications that we can use to counteract that. So here are nursing interventions for that epidural. Also can be used for a spinal. So that co-loading of some sort of crystalloid. We're going to be watching that fetal heart rate closely, monitoring that blood pressure very closely until stable, looking for bladder distension. Evidence-based practice tells us that we don't have to have an indwelling catheter for every patient that has every patient that has an epidural, but some facilities are still using indwelling catheters for the entire epidural length of time. That needs to be placed, obviously, using good sterile technique because she already is at higher risk of a urinary tract infection because of the stasis of the urine during the labor process and the frequent invasive vaginal checks that we're doing. We're going to be watching her oxygen saturation because we can also see a decrease in our O2 sat, and we need frequent maternal movement. I can't stress this enough. Once a woman gets an epidural, it is now the nurse's job to move this patient every 20 to 30 minutes into a different position, hopefully using a device like a peanut ball so that we can still help this baby make its way down into the pelvis. One of the things that when we first started using a lot of epidurals 25, 30 years ago is we noticed that there was an increase in the cesarean section with the use of epidural. And it isn't the epidural that causes the increase, it's the lack of maternal movement that causes fetal malposition that increases our cesarean section. So it is on us to now move this mom very frequently. Now, a little bit of talk about uterotonics. Oxytocin, there's a labor use and a postpartum use. So labor use is when we still have that baby on board. Oxytocin, also called Pitocin, that's the name that you'll see used in the hospital, is hopefully a standard concentration across the United States. I have a feeling that it's not, but hopefully. Everyone is using the 30 units in 500 mLs because then it makes 1 ml to 1 unit. This is a high-risk medication, requires an independent nurse double check. The use of this medication is the #1 reason we see fetal harm caused by our processes in labor and delivery. It is not to be taken lightly. Oxytocin should have very strict policies surrounding it. We should have very strict monitoring, and it should be the first thing turned off when we're starting to see fetal distress. If we are causing uterine contractions and seeing fetal distress, which is equivalent to a break in the oxygen pathway, then we need to be turning the medication that's causing that contraction off. I know some people will probably argue with me about that, but I stand pretty firm. That's what the evidence tells us. So it's not to be used in a patient that has contraindications to a vaginal delivery or has hypertonic uterine contractions. If a patient is laboring and has more than 5 contractions in 10 minutes or contractions lasting more than 120 seconds, then we are already at the point where they're having too many contractions and we should not be causing more. In postpartum, they use Pitocin to help to contract that uterus right after delivery. There's some evidence out there that talks about active management of second stage decreases hemorrhage. And so active management would be giving everybody Pitocin. There are plenty of nurse midwives and physicians out there that are not using active management of the second stage. And I'm going to leave that right there. That's it. There's some controversy about giving everybody Pitocin, but we do frequently see it used. Postpartum use is a larger dose because we don't have a baby on board anymore. And this is what the recommended dosage is, about 10 units in 30 minutes over 3.5 hours, a total of 3.5 hours to have this dosage put in. We don't want to bolus it. There are lots of issues with giving a big bolus, including water intoxication and uterine rupture and all sorts of things. So when a patient is on oxytocin and she's still pregnant, she needs continuous monitoring. When a patient has had her baby, we need to be watching her vital signs very closely when we are giving that large bolus dose of oxytocin. Here are your nursing interventions for oxytocin. And then moving into antihypertensives. So there's several medications that we can use to help our moms that have gestational hypertension. Whether you are following the guidelines that are out there about hypertensive or not in your facility, it depends on how proactive your facility is being. Most places are moving to a pretty defined policy on handling gestational hypertension. And so these dosages are created from the California Maternity Quality Care Collaborative, CMQCC, recommendations from their toolkit. So we do have labetalol that can be utilized, hydralazine, and there's our Procardia again. All of these can be used for blood pressure. Your ranges and your triggers that are going to cause you to use these, labetalol or hydralazine, usually providers choose one path or the other, or sometimes if one path doesn't seem to be making a difference, they will switch over to the other. But those values are going to be based on your provider. Just remember when you are giving these medications that we want to be watching our vital signs very closely and making sure that we're not hitting those maximum dosages. Nursing interventions that go along with your antihypertensive medications. Rogam is the medication that we give to a mom that is Rh negative and has delivered an Rh positive baby. So Most women that are Rh negative will also receive a dose in pregnancy, somewhere around the 28th week. And that is to keep this mom from developing the antibodies in response to an Rh positive baby. So the other times that we need to be giving RhoGAM, so it's given at 28 weeks in pregnancy, and then again within 72 hours of birth. But if there's been any potential exposure, amniocentesis, chorionic villi sampling, transfusion, termination of pregnancy, either spontaneous or therapeutic, abdominal trauma, or bleeding, we also need to be giving RhoGAM because we don't know if there was a mixing of the blood. And so RhoGAM needs to be given during that time. Does require informed consent from physician or midwife and a blood transfusion consent. Medications that we use in postpartum are going to be a lot of the same medications that we have already talked about. A couple of that different meds that can only be used in postpartum are mentioned here. These are our uterotonics. So in addition to Pitocin, which can be used both antepartum and postpartum, we have these in our toolkit if we have a mom that's hemorrhaging. We have Methergin that can be given. It is an injection. We have Hemabate that can be given. It's also an injection. We have tranexamic acid that can be given. It's an IV injection. And then we can also use misoprostol, which is our cytotec, at larger doses. So a couple of things I just want to point out here for our Methergin, and this is a famous NCLEX question. They always want to know, it is absolutely contraindicated in hypertensive patients. So if your mom had gestational hypertension and now she is postpartum hemorrhaging, which can happen and is a trigger, you absolutely cannot give Methergin because it can cause them to, it's a vasoconstriction and you can actually cause them to stroke. So you don't want to give your Methergin if they are hypertensive in pregnancy, whether it be chronic hypertensive or gestational. If they're hypertensive at all, this has been taken out of your toolkit. You do not use this one. Hemabate is contraindicated with asthma patients. So again, we have to know our patient's history in order to know what can be given. And in the heat of the moment, you as a nurse may be the only one that remembers that your patient was hypertensive or borderline hypertensive and that they have a history of asthma. And this is our newest drug that has been added to our toolkit, and we seem to be having pretty good results with this. Sometimes when a patient is hemorrhaging, we will use everything in our toolkit and then have to move on to other procedures to get that hemorrhage to stop. Here are your nursing interventions for your uterotonics. I'll let you read through that. One thing I do want to point out is when we are looking at vaginal bleeding, it is evidence-based practice that we are doing quantitative, meaning we are actually weighing it. We no longer visually look at vaginal bleeding. It needs to be quantitative. And I know when this came into practice, it was hard to change our workflow, and instead of just eyeballing it and guessing what it was, actually weighing it. But once you make the switch, you'll see how poorly we were able to estimate what those blood losses were. And then vaccines. Talk about our vaccines for our moms. There are a couple of vaccines that we highly recommend women get in the 3rd trimester because there's some referred immunity to these diseases for the fetus. So we get some, let's see, I believe it's IgG that is passed over into our fetuses from these maternal vaccines. So we recommend that all women have a flu vaccine in the 3rd trimester, and all women have an updated whooping cough vaccine in the 3rd trimester. Rubella is not something that can be given in pregnancy. So women who are rubella non-immune, which is rubella's German measles, or equivocal, and those titers are going, the titer is going to be less than 1, a ratio of 1 to 8. If they meet this criteria, they can have it as soon as the baby's born, but not during pregnancy. And then they need to not get pregnant for about 3 months afterwards, because this is a live vaccine and these are not live vaccines. Now, it used to be If the patient had an egg allergy, they were told to avoid vaccines. That is no longer the case. This is the current up-to-date information from the CDC. And even though they do use eggs to produce these vaccines, they've done extensive research and they do not see people with egg allergies having reactions to them. So it is no longer recommended that if you have an egg allergy, you avoid vaccine. And then the medications that we use in the newborns, there are just a few. We use an eye prophylaxis, erythromycin, and this is put into the eye to prevent ophthalmia neonatorium. It is required in all 50 states. Of course, it can be refused by the parent, but they need to sign a consent form, or they need to sign a refusal form, making sure that they understand why the medication is given. It's to prevent infection, specifically from gonorrhea and chlamydia in the baby's eye. And they need to know signs and symptoms to look for in the next week or so if they do choose to not have the erythromycin. Vitamin K is a medication given again to all 50 states require this, and it's to help synthesize prothrombin, and it is part of the clotting factors. So vitamin K is produced in the gut. We don't see a lot of vitamin K at birth. It takes about 7 to 8 days for that really to be built up. And those babies that are breastfed actually don't synthesize vitamin K as quickly. So we really want these babies to have this vitamin K available if they need it. Maybe they had some sort of trauma during delivery, or there are some babies that are susceptible to hemorrhagic disease of the newborn. So we give vitamin K to prevent that. There's been a big group of people that have chosen not to give this, and we've seen death in the last few years of newborns that could have completely been prevented with a dose of vitamin K. But again, it's a parent's choice as long as they're making an informed choice. And then hepatitis B vaccine is an option that can be given at birth. If we give this to them at birth, it gets that series started, and it means they'll have one less vaccine when they are starting their 1 month and starting their vaccine schedule. So hepatitis B is one of those blood and body fluid transferred diseases. So if mom is negative, baby essentially has no risk, but it is an option to get this started early on in the process. Again, consent would be needed for this one. So they need, in order to get informed consent, they need to know benefit, risk, and alternatives. And then they would also need informed consent about both of these to make sure that they know what the risks are, what the benefits are, and symptoms, side effects, symptoms to be looking for that they would need to report. I hope you have enjoyed this video and you've gotten something out of this studying medications. I recommend you make some sort of a resource that you can utilize at the bedside, in clinic. If you're a new nurse working in this area, this is a great tool that you could create, that you could tuck in your pocket, because remember, it's up to us to be our patient's advocate. Okay, see you next time. Here are my references.